they had bushes growing up like 3 feet over the fence line, you know.
Thank you all, and I apologize for interrupting conversations. We just want to get, in the interest of time, and make sure that we're respectful of everybody's time. So we're going to call the meeting to order at 6 o'clock. This is a special meeting with a special agenda this evening, so we will have time for public comment, but it will be at the end after our presentation. To start the meeting, I do need an approval of the minutes, so can I get a motion?
So moved. Second.
All in favor?
Aye.
Any opposed? Any extensions? Okay, so our, that is so moved then for our agenda. So now we're going to move on to our special meeting, which is an update provided by Carlene and team. So Carlene, I'm going to hand off to you.
Yeah, great, thank you. Carlene Jakowski, Assistant Director for Health and Human Services and Mental Health Director. And first, I just want to thank the local mental health board. I know that this was a month for the board to be dark and not have a meeting, and so I do appreciate you taking the time to hold the special meeting in order for us to go over the MHSA annual update prior to coming back for the public hearing. We have, I think, found, especially over the last few years, that it's been advantageous to sort of preview the annual update with this board, to be able to answer questions, start hearing some preliminary feedback from this body before just the public hearing, which closes the process. And so that's what we are hoping to do today. So I just first wanted to thank you all for making time. And then before I jump into my presentation, I just wanted to acknowledge that our agency director, Nolan Sullivan, is here tonight. And Nolan, did you want to say anything before I jump in?
No.
Okay.
Just a fly on the wall tonight.
Okay.
Thank you for having me. Thank you for serving.
Yeah.
Really appreciate it.
That's all. Just wanted to acknowledge Nolan's presence here today. Okay. So with that, I'm going to jump into the MHSA draft annual update for fiscal year 24-25. So the plan for tonight, Christine, if you can move to the next slide, please, is to do just a very general overview of the Mental Health Services Act. And for many of you, this is going to be very repetitive, but we always have new folks joining us, hearing this for the first time, or sometimes I've had to hear it many times, for some of this to really sink in. It's a complicated funding source. So we'll just do a very, very brief overview. We will talk about what our community planning process has looked like for this annual update. We'll go over some key priorities and the updates and changes that you'll see in this plan. Go over the budget overview and some of our fiscal projections. And then we'll just briefly touch on the transition to the Behavioral Health Services Act with the implementation of Prop 1 in 2026. Even though that's a little ways off, just want to sort of set the stage that some of the adjustments we're making now are in preparation for those changes. And then we will talk about next steps in the plan and approval process. Next slide, please, Christina. So as many of you know, there are 5 components of the Mental Health Services Act, and these are categories of services and activities that can be funded by the MHSA. So the first is community services and supports. That is the largest majority of how the funding gets broken out. Oh, and sorry, before I just dive in, the slides you have in front of you are different than the slides up here. I didn't send this to Christine until today, so she didn't have it printed out for you, but we're going to send it to you all. What you have in front of you is the update that I was intending to give you last month that we ran out of time for. So it might not be super helpful, and sorry, I forgot to mention that before I jumped in. But we will get this to you via email tonight. So the largest portion of funding goes to community services and supports, and of that portion of funding, we have to spend more than half of that money on full service partnerships. And so the pie chart you see to the right is actually how these dollars end up getting sort of pieced out at a percentage level. So 76% of our Mental Health Services Act dollars get allocated to community services and supports. And what that means is that a total of 39% of our MHSA dollars goes to full service partnerships, and 37% goes to general services delivery, which is sort of everything else that we fund out of CSS that's non-FSP. For prevention and early intervention, that's 19% of our total MHSA revenue that gets allocated to PEI. And of that 19%, we have to spend 51% or more of those dollars on programs or services that benefit children and youth under the age of 25. So you can see how that gets broken out here. It ends up being about 10% of our total dollars towards children and youth under 25 and 9% of our total dollars on other PDI activities. Workforce education and training and capital facilities and technology are both categories that are funded through transfers from the CSS category. So there is no percentage here. There's no specific dollar amount. We have caps on what we can transfer based on specific calculations. And those go to fund technology needs generally, and then any of our workforce education and training needs. So those don't have a specific percentage here in the picture. And then the last is innovation, and 5% of our funding is allocated to innovation. We always like to remind folks that No Place Like Home was an effort that was passed several years ago as a program funded by MHSA, and there's money sort of taken off the top to fund some ongoing work around No Place Like Home, and that happens at a state level as well. And then lastly, MHSA funds cannot supplant existing services or funding. So the community engagement process for this annual update began in January of 2024 and went through March of 2024. We held 5 hybrid listening sessions, one in each sort of major area of our county. We had one in Woodland, one in West Sacramento, one in Davis, one in Winters, and one at the Esparto Health Center. We had, I'd say, low in-person attendance, although the local mental health board really showed up. So kudos to you all for your participation and engagement in those sessions. We did have folks joining via Zoom, via a virtual option, and we did have an online community survey and 5 key informant interviews for a total of 193 individuals who provided feedback for this annual update. That's a lower number than we see for the 3-year planning process. We also have a bit of a scaled down version of the community engagement process for the annual update versus the 3-year. The draft plan was publicly posted on October 31st, and it will be open for public comment, the 30-day public comment period through November 29th. That's when the public comment period will close. And then lastly, we are doing these draft plan presentations. So this is the first presentation here tonight. We will be presenting this overview to the Board of Supervisors next week. And we also have a QG, a community engagement work group that's scheduled for the 19th, where we will present this information for a broader audience of the community and answer questions and hear feedback there as well. Next slide. So through our listening sessions, there were a number of themes that arose through the feedback that we received, either through the in-person or hybrid listening sessions or through the community survey or stakeholder interviews. So the first sort of section or of theme here is around understanding community perceptions. And so there was quite a bit of feedback received around just community mental health and emotional well-being, about frustrations with the system, some mentions of folks sort of being in survival mode, and what does that mean in terms of having difficulty accessing services or getting basic needs met before you can actually even think about addressing your behavioral health needs. There were lots of conversation and feedback around misconceptions and stereotypes related to mental health and substance use disorders. People provided input around cultural perceptions of mental health, educational barriers, sometimes misinformation that exists. So there was, I think what our contractors who sort of helped us through this process really noted in their summary and analysis is that there is sometimes a pretty big divide between community perception around what services are available, whether they're free, what funds them, does insurance cover them, and what our stakeholders or staff or partners from different organizations might know, and that gap was pretty large. And so that there is an opportunity to do a better job of educating the community around what's available and ensuring that that we're sort of closing that knowledge gap so that services are easier to access. And then of course there was some feedback and conversations around stigma related to accessing services. Some other feedback was around identifying needs, so mental health and substance use challenges or issues in the community. So there was feedback around difficulty engaging, and a lot of this feedback very similar to what we hear in all of our community engagement processes for the Mental Health Services Act. So difficult with engaging in services, and then just the impact on families and communities of behavioral health sort of challenges. So a lot of, I think, family member feedback that was heard through the listening sessions in particular. There were groups that were identified as needing extra support, so non-English speakers, and lots of feedback around cultural and linguistic barriers to service access, around vulnerable populations that might have specific needs, and that included the LGBTQ+ community, and other special populations in our community, and then systemic issues in terms of continuity of care. So, sort of ongoing feedback around how challenging the system can be to navigate sometimes, and that sometimes there are breaks in the continuum of services or service delivery that contribute to people maybe decompensating rather than getting better. Next slide. So then, of course, access to services is always, I think, a pretty widely discussed topic during our community engagement work and in feedback sessions. And accessibility was a hot topic for sure. So there was feedback around systemic and bureaucratic challenges. And so, those included things like just hurdles to overcome within the system of care. There is a ongoing perception and I think experience of folks that people have to be incredibly ill in order to be able to access the level of care that they need. And so that continues to be a topic, I think, that we're hearing feedback about or that is being discussed in these sessions. And the complexities of insurance and navigating insurance was something that was talked about here. Limited service capacity, and then sometimes long wait times for appointments. So, and that can hinder people from accessing care, and of course can have a detrimental impact on treatment and recovery. Navigating the system was described as daunting, especially for those who are unfamiliar with the process. And so a lot of feedback around how promising approaches or practices around navigation can really benefit the broader community. So, the Davis Navigation Center was sort of noted as something that's working well for the community, and that having that model more readily available elsewhere in our county could really be beneficial. So we certainly heard that feedback as well. And then some similar things that I've already mentioned, some lack of providers or service accessibility, and then opportunities to improve outreach in public education. Cultural sensitivity was another topic, and again, talked about cultural and language disparities, stigmas, and this comes up pretty often. People did talk about having a level of shame in discussing mental health issues or even accessing care, and sometimes the lack of multilingual services that are effective. And then there was some interesting feedback too around a distrust of online resources. So, in a day and age where we rely so much on computers and virtual, online dissemination of information, I think it's good feedback for us. It sort of challenges us to think about other ways that we can get information out to the community. There was feedback around socioeconomic constraints, so how financial hardship and the lack of being able to meet basic needs really sort of trumps the accessing services for behavioral health. And, as an integrated health and human services agency, certainly a topic that is important to us in terms of food security and, just being able to meet basic needs, and especially with the increasing cost of living, especially in Yolo County. And then, feedback just around the importance of multilingual service provision, around having representation of providers is inclusive, so having culturally reflective service provision. Some feedback around reframing terminology and perceptions, around destigmatizing language, around accessing care, and then doing more targeted outreach to marginalized groups. And then some just additional topics related to access to services. So recommendations to improve access included enhanced educational outreach, community outreach, increased peer support, having culturally competent services, using innovative service models, integrating services with other community institutions. So identifying ways where we can integrate the work we're doing into other institutions, facilities, settings where people are going to access services or where they're comfortable in our community. And then of course, the piece I just spoke about, which is technology and how we disseminate information. And then there was some specific feedback, I think, that came maybe during some listening sessions, but I think also primarily during the key stakeholder interviews around just the challenges around the MHSA fund allocation. And so the need to really lobby for policy change, to enhance support for caregivers and therapists, really talking about burnout, right, that's being experienced, and some of the workforce crisis we're seeing in the behavioral health field, and that's not just unique to YOLO, right? That's a nationwide challenge, and the importance of building supportive communities. And then there was sort of one more theme that stood out, and that was really around the need to build and establish a comprehensive system of care. I think at times it can feel like our system of care is a bit siloed or broken in parts, right? Some pieces are quite strong, other parts need a lot more resource or a lot more attention. And so really building out a more comprehensive continuum so that folks can easily access services and transition between the levels of care that they need. Okay, next slide. Thanks, Christina. So that brings us to this annual update and the key priorities. And so, I think when you look at my executive summary or just the key priorities in this annual update versus the 3-year plan, I think one of my employees said it's pretty somber, right? I mean, you read it and it's not, and I agreed, right? The 3-year plan, we were looking at, the sort of record level revenues and a lot of growth in our plan. And so that was a much nicer executive summary to write, I have to say, right? This one was a bit difficult because what we're really having to do is do some level setting and have some sort of honest kind of framing of where things are financially in terms of the fluctuation of MHSA revenue, and then also the uncertainty of the transition period ahead, right, and being able to prepare for that. However, with that being said, I think what I want to underscore and say here is that there is an overall, in general, I'd say, sort of maintenance of certain levels of service, right, for many of our categories in the MHSA plan, for many of our programs. We were very intentional, I'd say painstakingly sort of detailed around the cuts that were made or the adjustments that were made, and they were difficult. And that is in part why this plan is quite late. We waited until we had actual closeout of our last fiscal year because it was really important to be able to understand what kind of fund balance we were carrying over. The picture looked really dismal actually before the end of the fiscal year when we weren't sure how things would close out. And it improved a little bit once we were able to get to the closeout of last fiscal year. So the wait, I think, was beneficial because we would have made even more cuts, I think, had we executed this plan months earlier. And so while waiting is difficult and it puts us on a not ideal timeline, I think it was the right thing to do this time around. So there was several key strategic priorities that I discussed and sort of came to agreement with our internal team, and certainly as we're considering the community feedback and working on this annual plan. And so these were the priorities that helped drive our decision making, right? So I think it's really important for you to know as we were looking at programs, as we're looking at pieces of our plan, this is the lens that we're looking at things through. And so the first was to, of course, ensure compliance with our MHSA categorical spending requirements. We cannot put forward an MHSA plan that does not meet all of those specific requirements that we talked about earlier. So we have to pull that front and center, right? We have to meet those categorical spending requirements. The second was to minimize impacts on service delivery while prioritizing direct client services. And so what that meant is that we had to take a hard look at some of the internal infrastructure we built up over the last several years, which is desperately needed, right? Infrastructure that's helped us to improve our data collection and some of our outcome, reporting, internal infrastructure that's helped us better manage contracts and the programs that are funded by the MHSA, but are not providing direct services. Positions that were 100% funded by Mental Health Services Act dollars and that aren't leveraging Medi-Cal federal entitlements. And so we did make some reductions in staffing in those areas, which I'll talk about in just a moment. I think we're gonna do questions at the end, but I'm happy to
This
You want
is just,
position to
just
clarify?
about the fund balances.
Sure,
At one point, we had a pretty healthy
Yeah.
fund balance.
yeah,
I'm gathering that that's pretty well spent.
yeah, and I'll share some
Oh, okay.
information about that, yep, in a
Okay.
few slides.
All right.
And there's a slide that, yeah, and I think that's a great question, Nikki, and there's a slide that we're working on actually for the board meeting, it's not finalized for tonight, but once I do have that slide finalized, it's just gonna show our fund balance year over year. I will share it with this body, so you're able to look at that as well, but yeah, you're right, and I'll give some data around that. The third was to maximize Medi-Cal revenue by leveraging MHSA funding for federal entitlements. And so what that means is that we are prioritizing using MHSA dollars as our match to draw down those federal entitlements. That's a requirement under Prop 1. It's very explicitly required under Prop 1 and directed to counties. And so this is a step to prepare us for that transition as well. The next was evaluating eligibility of our current MHSA programs for continued funding post-Prop 1 implementation of July 2026. So it was really important for us that we don't have a cliff on June 30th of 2026 and that we start to take a hard look at some of our programs to see if there are some programs that needed to transition out or change sooner and some that changes and transition are still yet to come. And so we are trying to ease our way into some of the changes that are coming. Because in addition to our categorical funding changing under Prop 1, the way we provide services is going to change dramatically. So what was also embedded in Proposition 1 was requirements for us to implement a number of evidence-based programs that we don't currently offer. All of our full-service partnerships will have to be implemented through evidence-based programs that are not currently provided here in our county. And so there's a lot of work that's going to be coming that's going to be huge changes to the way we deliver some of the services we fund under MHSA now, primarily under our full service partnerships. And I can share more about that in the future, but just as a sort of, just want to put a pin in that for you all. The next was utilizing data-driven decision-making. And so that meant really taking a hard look at outcomes and looking at our results-based accountability and looking at programs where the outcomes may not be ideal, or they may not be what we were sort of hoping for in some areas, and right-sizing our plan and our budget based on our changing MHSA revenue projections, which I have some data to share with you for that. And then the last is one addition to our plans. This is the only new thing that you'll see in this plan is one-time capital funding for the acquisition and rehabilitation of an adult residential facility, and that's the second Pine Tree Gardens. And so those are some one-time CFTN costs that will support that home being under the same ownership as the other home, which is through Yola County Housing's nonprofit arm, New Hope. And the county does subsidize the operations at both of those facilities through MHSA funding. And a small set aside of funding for a match for a state program that provides funding for rehabilitation of adult residential facilities, and so we intend to use those funds here locally for both Pine Tree Gardens homes. Okay, next slide. So these are the specific changes that you'll see in this annual update. So for our community services and supports category, we will be reducing our contracted FSP slots. So those are specifically the full service partnership slots that are contracted to our current contractor, which is Hope Cooperative. We had planned for an increase up to 240 over this 3-year plan. And we will be reducing that back down to what we consider to be our core baseline of 200. I'll share just a little bit of detail here. We first increased to 220, and then we planned for a second increase to 240. Hope Cooperative has never had more than a census of 220, even after we expanded slots to 240. Staffing issues and other barriers have prevented us from really fully utilizing that expansion. And we have to right size our slots because we can't pay for staffing or for operations when there aren't clients in those slots. And then through attrition, we intend to reduce those additional 20 slots. And some of what we're working on the other side of things are strengthening our internal FSP program, which is our forensic program, and looking at what opportunities are lying ahead with the evidence-based programs we will need to implement for FSPs, which include ACT and FACT. So that's ACT programs and then forensic ACT programs. And that's going to be a requirement under Prop 1. The second was a discontinuation of a case management program at Pine Tree Gardens. This was funding that was added during times of plenty, I say, under MHSA, and it was specifically to sort of strengthen some services that were being provided at the adult residential facility. But we have discontinued that, just that component. We're still funding or subsidizing the operations of both facilities. The second was the discontinuation of the behavioral health case management program for the public guardian's office and an elimination of 2 MHSA positions. So we were also subsidizing in some way the public guardian program by assigning 2 behavioral health case managers to that program for the last several years. We've been able to strengthen the actual staffing we need in that program with conservatorship officers, primarily through the advocacy of this board to our Board of Supervisors, which we're very grateful for. And the behavioral health case management program through the Public Guardian's Office wasn't able to bill for Medi-Cal, wasn't leveraging those federal entitlements. And so those services are better provided through our behavioral health teams under our behavioral health staffing and supervisors so that they're still serving conservatees who are on LPS conservatorship. So they're still getting behavioral health case management services, but not through staff that are embedded in the Public Guardian's Office, if that makes sense. And we have expanded our staffing in the Public Guardian's Office by adding 3 additional conservatorship officers, which is incredible.
Yes.
They're onboarding and training now, and so it's just really exciting. And so the
That's
program,
like doubling it, isn't
it
it?
is more than doubling
More
the
than doubling.
conservatorship officers. Yeah, we had 2,
Yeah.
so it's wonderful. And so the next was a discontinuation of a supportive housing and social services coordinator program. That was contracted to YCCC, and it was specific to a program. It was shared time between One Housing Program and Pacifico. There were changes at the city level around the housing support that was happening at that site. And so this was sort of a natural ending of this program, but it also aligned with our funding priorities that we talked about previously. There was no Medi-Cal reimbursement for these services. It was 100% MHSA funded. So this is one of those things we would not be able to continue under program. We eliminated an additional 2 HHSA administrative support positions. That was a program coordinator position and an analyst position. I think the other thing I just want to add here is that we didn't lay off any staff in this process. That was really important. We had other vacancies within the branch or the agency for lateral transitions for folks that made a lot of sense, or folks applied for and received promotions or transfers into positions that they wanted to move into. So everyone whose position internally ended as a result of this was able to land in a position of their choosing or of the equivalent status for them. So there were no layoffs associated with this, which is really important to know. The next is a transition from our Davis Navigation Center being operated by a contractor to it being operated by the county. And so that was a financial decision. That decision comes at about a $500,000 a year savings to the county. And there's a few reasons for that. It's a little bit of a different staffing model that we're using there. And there was very limited Medi-Cal revenue that was being generated through that contract, which I think we have a little bit more control over when it's our internal staff. That's our front door for our mental health plan. And so we should be billing quite a lot of those services to Medi-Cal. And so a little bit of a shift in an approach for us as well to leverage again Medi-Cal. Whatever Medi-Cal revenue we bring in through MHSA programs helps offset the MHSA dollars that we need to spend to fund those programs. So we are projecting about a $500,000 savings from that change. The next is a transition of the NAMI peer and family-led support program from being funded under the community services and supports category to being funded under PEI. The program very naturally sort of fits under PEI. We did some research and other counties fund their similar NAMI programs under PEI, and after lots of back and forth with our partners at NAMI YOLO, we were able to sort of present that as an option that they had got to say if they wanted to do or not. So they agreed to. And there's some additional data collection that's going to be required as a result of that. We have more different data requirements under PEI and some changes that they'll see, sort of some things they'll be adding to the way that they run the program. But this is a sort of natural shift. It's also helpful to us because the CSS category is where we see the most funding strain right now. And so that was a win-win situation to make that shift. And then the last is that we just had an overall reduction in our transfers to capital facilities and technology needs. So we used some one-time incentive funds that the county received for participating in a DHCS incentive program to help pay for a portion of our electronic health record for the year or some other costs that usually come to CFTN. So this is one-time offsetting of those costs for this year, but all in an effort to do some cost reduction to our CSS category. Okay, next slide. These are the changes for prevention and early intervention. So this is really limited changes here. The most significant change you'll see is the discontinuation of the CREO program, which was contracted to Communicare. It's our Latinx outreach and promotores program. What's really important to note here is that many components of that program had other funding associated with it. So there is quite a lot of the program that's actually continuing without the MHSA funding. What did go away, I think, was the therapy services that were being provided through there. Although I understand that Communicare is offering therapy to those clients through their FQHC model, and because they can bill Medi-Cal. This is another sort of difficult contract for us to have to make some decisions on, but MHSA was not being leveraged to bill Medi-Cal. Medi-Cal was not being billed for this contract. I think the data showed that about 50% of the participants were Medi-Cal eligible, so we could have been having some services billed to Medi-Cal, and so we had to make a shift there. Luckily, because the program had a blended funding arrangement, there are many services that are continuing without the MHSA funding, but that program did end under this.
Sorry, and QHC.
Sorry, a federally qualified healthcare center. So because of that status, they're able to bill for mental health services at a rate that actually exceeds what we pay them for these services. And so so they have a pretty robust behavioral health program within their primary care. The other change you'll see here was the elimination of 2 administrative service analyst positions within HHSA that were specific to PEI. Those positions were both vacant, so there's no staffing change or loss. But those were both positions that we would be able to continue funding under Prop 1. So the dilemma we had was, do we fill them as limited term positions for the next year and a half of this plan, or do we eliminate the positions? And it felt more appropriate to eliminate those positions now than to bring someone on. We have analyst vacancies all the time in our agency, and so hiring a limited term analyst would be very difficult because we have permanent positions all the time that are available. And then the last was the discontinuation of the mobile hair professionals program, which is a very small program in our PEI program, but those services were continued with other funding. And so there's some homeless services funding that was provided to the program, and so they are continuing the services, just not through MHSA. And that is one of those really unique programs that we loved. We loved funding. That really was a very small investment and has a really profound human impact. But is one of those programs that is explicitly sort of carved out of Prop 1, and so so the timing was good that they had other funding they were able to secure for us to then transition out of it. Okay, the last category where you'll see change is in our capital facilities and technology needs. And so I've already talked about this a little bit. We're utilizing some one-time incentive funds to offset our annual subscription costs for our Avatar electronic health record. So that's a reduction. And then the one increase you'll see is one-time capital funding for the acquisition and rehabilitation of the second Pine Tree Gardens home, which is an adult residential facility, and we subsidize those operations through MHSA already. Okay, the next slide. So this is just a little bit of an overview of our budget priorities, or just some things that I think are sort of top of mind for us around budget. So the first is revenue volatility. MHSA is a pretty volatile source of funding. It depends on the tax actions of individuals with personal incomes over $1 million in the state of California. Our actual revenue over the last 3 years has ended up being over 20% lower than what was projected. And we build these plans, these budgets based on projections. And they're not our projections, we don't make them up. There's statewide experts who give us those numbers. And so every county received these same projections. Every county's revenue was quite lower. Other counties, I think, are carrying a much larger fund balance than we are. So maybe the volatility hasn't impacted. So, there's some counties that have very similar impacts to us. So for Yolo County specifically, over just the last 3 fiscal years, so 23, 24, 22, 23, I'm going backwards, so I'm having our 21, 22, our actual revenue was $12.4 million less than we had projected, which is very significant for us. 1 year of revenue for us is usually around 17 million. So we're talking about the equivalent of a large percentage of what 1 year of revenue would be for MHSA that fluctuated for us. And then in terms of fund balance, the revenue fluctuations coupled with the rising costs and the prior growth plans that we did execute in our previous fiscal years have really depleted some of our fund balance, unspent fund balance. And our expenditure plans have outpaced our revenues. So again, there's a slide where I'll sort of walk us through that a little bit. Program reduction, so we recognize that some reductions were needed to the current annual update to ensure a more financially sustainable plan through the end of our current 3-year plan. So that ends in fiscal year 25-26. We have 1 year after this year of this plan, and then we move into Proposition 1 planning, so a sort of new world for us. Prop 1 preparation. So we recognize that preparation is needed for the upcoming changes with the transformation and implementation of the Behavioral Health Services Act, which includes reevaluating our priorities and what we're funding with these dollars.
Pause for just a second.
Yeah.
We've gone over a lot, and I think we can make that.
Yeah, I just wanted, before we got too far, to let everybody here know that the reason we have Pine Tree Gardens, is through the very generous donation of Kathleen Williams, who's here, Boswell Williams, who's here tonight, and I want people to know, you know, not everybody is able to give a piece of property that's valued at well over $1 million, particularly for this kind of use. And the mental health community in this county should be eternally grateful.
Thank you so much for that.
The work that she's done.
Yeah, thank
So
you.
happy to do it. My parents set it up, and I'm so happy I can help my folks put it where it's in a safe place, can be used like it is for 99 years,
Yes.
just like Pine Tree Gardens East. It's amazing that you were able to do that. Thank you.
Thank you, Kathy.
I'm really happy I could help.
Thank you.
Sorry for the digression,
No,
but
I appreciate you doing that, Nikki. Yeah, thank you. Okay, so we'll go to the next slide. So this slide is just a demonstration of that difference between our estimated and actual revenue that I was just sharing with you all. So when we look at fiscal year 21-22, our actual revenue was $667,000 less than we had projected, which isn't a significant fluctuation. Our fund balance certainly, was fine to cover that. Where we see the most dramatic and significant difference is in fiscal year 22-23. Our actual revenue was $6.9 million less than was projected, which was a significant loss to us. And so the way that MHSA revenues come in are their monthly deposits into the Mental Health Services Act account. And so we don't know what our annual revenue is until the end of the year, right? And the actual deposits we get can fluctuate depending on the tax actions that have happened. What happened uniquely in fiscal year 22-23 is that several tax deferrals were offered because of storms and other things. And so people were able to defer paying their taxes, and those deferrals had direct impacts on our revenue for that year. So for fiscal year 22-23, we dipped way into fund balance to close out the year because our expenditures far exceeded what our revenues, were for that year. And we had a hefty fund balance at that point, and that's the slide I'm working on, Nikki, that I'll share with you all once it's done. We had a hefty fund balance at that time, so, but it still was unexpected, right? And we had planned to spend down that fund balance a little bit over these 3 years, not spending 7 million of it or 6 million of it in 1 year. So that was a significant change for us. And then last year, biggest year we've ever had. And so I just want to give a note here. That's an abnormal year for MHSA revenue. Then that's due in part to, so there's a true up process with MHSA, and we get a larger deposit once a year. For the most part, 1 year, I think it came in actually less. So there was a reduction to counties, but it's where there's a true up of the prior year's revenues and what counties received in terms of their MHSA dollars, their actual revenues to the county, and in 23-24 was the largest true up we've ever seen. statewide. And so every county got a significantly higher, we still got significantly more MHSA dollars last year than we have, almost double the year before, so that's significant. Some of that too is that the tax actions came later, right, because of those deferrals. So some of the revenue we would have seen in 22-23 actually came in 23-24, but it was still lower than we projected. And we planned based on our projections, we planned based on having more fund balance than we had available. So we saw $4.7 million less in revenue last fiscal year. And then that brings us to the projections for this fiscal year and next fiscal year, which are right around 17 million total for MHSA. So we'll see how the year turns out. The next slide is our budget summary for this plan, and that's in the annual update document that I think you all were sent when it posted. And it shows what led into last fiscal year and then what led into this fiscal year. And so you can see where our fund balance has sort of been diminished over time. We had quite a bit of fund balance spent the last 2 fiscal years to shore up the fiscal year because of those revenue fluctuations. And we are projected to carry over some fund balance into next year. And I just want to note that we think that's important because of the revenue fluctuations, because of some of the uncertainty around sustaining some of what we consider core programming that's been built in this community over 20 years of MHSA and the requirements that are coming to us under Prop 1, that we feel like having a cushion and some fund balance carrying over is really important. So we don't want to plan to spend every single one of our CSS dollars or PBI dollars this year because we want to make sure that we're setting ourselves up for success for next year and to help transition some of our programs moving forward. So this is the budget for this annual update. And then the next slide is just a reminder of the changes that are coming with Prop 1 and our categorical spending. And so we're going to have reduced MHSA dollars overall because there's more coming off the top at the state level. So I think that's important to note. There is 3% that's going to state administration, 3% going to statewide workforce initiatives, and that's going to HCI. And then there is 4% that's going to population-based prevention services, and that's going to the California Department of Public Health. And so there's 10% coming off the top at the state level, which means that 90% will end up being a county allocation. And right now that is a 5%. There's a 5% taken off the top. So that's, that is significant. And then when we look at that 90%, that's the more colorful pie you see there on the right, that shows our categorical spending requirements under Prop 1. So instead of having 5 categories of spending, we'll now have 3, and that will be 35% to full service partnerships, 30% to housing interventions, and 35% to behavioral health services and supports, of which 51% of those dollars must be spent on early intervention, of which 51% of those dollars must be directed to children, youth under the age of 25. So some similar requirements that we see under MHSA, but those pots of money are getting quite small.
I was going to say the pie's getting smaller.
It's getting much smaller. Yeah, and I think the biggest change that some of the big changes we'll anticipate to see locally, we will come back to this body with a more, I'd say like a more detailed analysis of what this will look like for us once we can dig in. We need to get through this annual update and then we'll really start doing some local analysis. But for us, 35% in full service partnerships is actually slightly less than we've been spending on FSP. For some counties, it's quite a bit more. So it sort of really varies from county to county depending on their revenues and their spending plans. And the biggest change for us is that we do not currently spend 30% of our MHSA on housing interventions. We do spend some FSP dollars on housing, and we do spend some other dollars on housing, like subsidizing the operations of Pine Tree Gardens, right, which is about $1 million a year for us right now. But we don't spend this much money. And of those housing supports, 50% must be spent on individuals who meet the definition of being chronically homeless. And so that really sort of narrows down how we will spend those dollars as well. So that's a big one for us to unpack there. And then that behavioral health services and supports is kind of a catch-all of everything else, but it's intended to fit lots of things right now that have much more funding attached to it. So the next steps for us are going to have to be being very strategic about how we leverage other funding sources, about what we back out of MHSA and how we do that, because we don't want to have service impacts to the extent possible with this transition. Okay, the next slide. So these are just the next steps for the Mental Health Services Act annual update process. So like I said, the annual update was posted for public comment on October 31st, and it will be open through November 29th. All of our public comment through the online system, it's captured through a form, and so we get that feedback right away. We'll start working on formulating responses to those and feedback to the comments that we get through that process. And then certainly there'll be the public hearing here as well. We are previewing this draft fund plan and annual update here tonight. And as I said earlier, with the Board of Supervisors next week and at the Community Engagement Work Group on the 19th. The local mental health board, you all will hold the public hearing at the next local mental health board meeting on December 4th. And then the final plan is anticipated to go to the County Board of Supervisors on December 10th for final approval. And I will just say that those timelines for us are tight and important. We're really backing into some of this timeline. The December 10th date is pretty important for us for approval. The board goes dark for almost a month, actually over a month after that. The next board meeting isn't until January 14th. And so we will do our best because we get that feedback, like I said, through public comment throughout the month. So as the comments are coming through, we will work to provide probably some waves of feedback to this board so that you can begin reviewing that before the December 4th public hearing, but we'll also present it to you then, the feedback and
But at this point, you're gonna be 6 months into this.
That's right.
Or-
That's right.
Yeah, okay.
Yeah.
I just wanted to be.
Thank you. Yep. Yep. And that's quite unusual, right? It's not ideal.
No.
And like I said, there was a number of factors that contributed to that. But as we got further along past the deadline, right past when we should have had this approved, it became clear to us that waiting to close out fiscal year 23-24 was really important. So that we could have, like I said, the better sense of what fund balance was and not projected. So we had more concrete numbers because we were talking about cutting programs and eliminating positions, and we wanted to be very, very certain. So it is quite delayed, and that is my least favorite thing about this year so far, how delayed this is. And I feel confident that we'll be in a different place next year, but this is sort of where we are this year.
I do want to just add really quickly though, and I think we're seeing this not just in this program, but other programs across the county. When you get into a situation where you no longer have a fund balance, you no longer have a safety net, right? So you can't gamble, you can't estimate, you can't guess. You literally have to depend on the dollar. There were several points over the last couple months where we thought we would actually end with a negative, but we didn't think we'd have a fund balance at all. In fact, we thought we'd have to borrow money from elsewhere or kind of panic.
Or cut more.
And so to Carlene's point, I know she's optimistic and is saying that it should get better next year, but I don't think it's going to get better, frankly. I think the county right now is really struggling with general fund. We have one of the lowest general fund contributions to Health and Human Services out of all the Health and Human Services agencies in the area. Frankly, we don't have a cushion. We're kind of flying without a safety net. And so it's going to get worse. It's going to get harder. Carlene has been very modest. She has worked, no joke, probably 500 hours on this over the last couple of months. This is probably the hardest plan that we've ever put forward. And frankly, at first it was kind of the apocalypse doomsday plan. And we've been in a place that actually is really well done. And a lot of that is because of Carlene. So I do want to level set. There are going to be more delays. There's going to be more cuts. Prop 1 is not great. The pizza is actually much smaller and it's much less flavorful, if you will. There's less toppings on it, right? And so it is not working out well for Yolo County. So
Surprise.
right, yeah. And hence, the reason it barely passed, and you have a lot of folks in the mental health profession sitting back, and it really is not a great thing for us. So I hate to be the negative person in the room, but it's going to be a rough couple of years. And the better prepared we are for Prop 1 being implemented, the better off we're going to be once it comes, right? And if you think Carlene's point about not having a cliff and having kind of a soft landing is she's doing a really wonderful job preparing for that. Simultaneously, you guys heard about, 6 or 7 FTEs being cut. That work has to go somewhere. And a lot of that has gone to her. A lot of it has gone to other places. So it was not an easy shift. And although we found jobs for other folks, we don't have the administrative staffing on the back end to do wonderful, amazing analysis and process all this data. So the lion's share of this is falling on her and some poor staff and Tony. And so I just want to acknowledge that they've been absolutely amazing through this process, and they make it look easy, but it has been anything but easy for the last couple of months. And like I said, it's going to get a little worse before it gets better.
Thanks, Nolan.
Sorry.
No, it's fine. I cried a lot of tears over this plan, I'm not gonna lie. Okay.
I might be there.
Time for questions at all, or?
Yeah, let me just, the
Okay.
last slide is just, I just wanted to, it's just our acronym slide. So, we use a lot of acronyms. This might not be all of them, but we tried to capture them. So any of the ones that are in this presentation, or that might have been in this presentation, we try to capture. As you might have seen in the annual update, there's a much lengthier acronym document in the actual MHSA plan. Because if there's anything we like in behavioral health, it's acronyms. So that does conclude my presentation, and I'm happy to answer questions.
Where is Crisis Now in all this?
Yeah, that's a good question. So Crisis Now has some innovations funding attached to the planning process. We would need to go back to the MHSOAC, the Mental Health Services Oversight and Accountability Commission, with a new innovations plan if we want to fund more, like a broader components of Crisis Now. Crisis Now, though, is really moving along quite well, actually. So every piece of the continuum is implemented except the receiving center. We are well on our way, though, with our general services and with our construction team. We will be putting up a new modular building at the site we had previously located for this project. We actually received grant funding from the BSCC for our Crisis Now project. That's going to help some of the operations of the facility. It was under a specific grant, but it's for behavioral health deflection, right? So having a place for folks to go and they're experiencing a behavioral health crisis, that was wonderful because that helps shore up some operations costs.
Right.
We have funding for the capital facility, so we're in a really good place. Our anticipated launch or opening of that site is late summer to early fall of next year, as long as all goes, according to plan. But we're making good progress. And we're working with our city partners. I mean, some of the pieces I think next are, our city partners have made, what would you say? They've made promises.
That they have not followed through with yet. So we do have a little over $1 million promised to be contributed from our 3 biggest cities. We have an MOU for shared service. There's a little bit of apprehension for whatever reason. We were hoping to have those MOUs signed and have funds collected by July 1st of this year. That has not yet happened. So there's about $1.2 million that we're looking to collect from the cities. There is some contemplation about a Prop 1 first round grant maybe going in to assist. The problem with that is timing. I mean, we
For the
can,
bond funding.
for the bond
facility,
funding, and that would supercharge the project, but it would also delay the project. So we're kind of going through that now.
We're weighing the benefits and costs, right? That's funding.
This is why I was really worried about Prop 1, because I was concerned we were gonna get a center all ready to go and not have the funding for staffing it and doing it the way it needed.
And that's what the more money we can take from capital improvement to preserve for services, the better, right? So
Yeah.
every grant, every opportunity. The problem though, shovel ready right now, according to Prop 1, is like 2026. That is nowhere near shovel ready. And so that's a concern for us too. But we're
We
waiting.
want to launch in
we're waiting
2025, so the timing might not work for us with the BCHIP, which is the Prop 1 bond fund. So the Prop 1 had 2 components, right? A bond for actual facilities, and then the changes to the Mental Health Services Act, which is what we're talking about today. And so we're weighing those costs and benefits right now. We do have a pre-application in, which was required, and we have a meeting next week to go through our pre-application for bond funding for the facility. But we just don't know yet if we're going to actually submit the full application, because it will come with delays to
December
the project.
15th, yeah.
Yeah, so we have some time to decide.
Yeah, but I would advise this board to actually have an updated presentation on Crisis Now at some point in time in terms of the services. The 24/7 mobile crisis response is phenomenal. Call center stats are great. The people and the person to call is up and running and working really, really well. 30-day beds are working well too. The 24-hour mobile crisis response is very expensive. Carlene and I have been racking our brains on how to pay for that. But so far, the data between the embedded clinicians, 24-hour mobile crisis response, and the call center that also serves as 988 and suicide hotline is fantastic. And we have data for the last year, roughly. So Crisis Now is up and running. It's just we don't have the hub, the place yet, and that's what's coming next.
Yeah, Melanie had a question.
I don't even know if I'd throw care court, how does that,
Yeah,
so
that's a
what
good
are the
question.
funds as far as care court, is that gonna be part of MHSA,
Yeah.
or is that gonna be separate? Is
Yeah,
there a
so,
way to draw money from there?
yeah, there is. CARE Act didn't come with any dedicated funding it came with minimal funding for implementation. The county got, I think, $200,000 total for implementation, which, has to support a wide variety of things like changes to our electronic health record, and then also the court, we're not the only partner who's involved with the CARE Act. So we are preparing to launch the CARE Act on December 1st, so that will go live. I'm happy to come back and do a presentation here, whenever it works for this board to put that on the calendar. I know we've got MHSA things taking up a couple of meetings, but our courts are ready. They're ready to accept petitions. We're working on finalizing some things on our side of it, behavioral health. Right now, we're using existing internal staff dedicating to CARE Act, so they're going to be doing sort of, double duty in terms of our forensic staff. So with their training and the assessments and all the court processes and the petition, all the paperwork that comes along with it. So we'll have clinical staff assigned. We're hoping that as we start to get petitions in, that we start being able to bill for some of the work we're doing, we'll be able to justify adding some staff. But unfortunately, because it didn't come with implementation funding, we can't add staff based on what we think is going to happen. And, the CARE Act has had lower petitions across all of the counties that have implemented already than they anticipated. And so we really feel like the first 3 to 6 months will be a time for us to gather data, look at billing, because we are going to be able to bill for some things that are not Medi-Cal billable. So that will be helpful in terms of getting the program sort of ramped up. And then I think once we have a bit of data, we'll be ready to come back to our board and say, here's what we need to actually really have a more robust CARE Act team. But we're going to be using existing staff in the meantime.
I think to add to that really quickly too, Melanie, the numbers that Carlene's referencing in other counties are incredibly low, almost non-existent low. So there is some propensity right now, I think, in the mental health space where things are being a bit politicized as these grand solutions and these amazing things that will solve problems, but frankly, at the ground level, they're not doing a whole lot. CARE Act is probably one of my lowest worries right now, just because of the numbers across the state are still incredibly low, and it's because of a variety of reasons in the way it was designed, and very specific diagnoses, and you've got to meet certain criteria. So the numbers in YOLO are going to be next to nothing, probably, at least right off the bat. So again, it's kind of, Prop 1 was the same way, and Ms. King, you mentioned this earlier, that a lot of these grand announcements for these big sweeping tools and plans that frankly don't make sense at the ground level. And so CARE Act is probably not something that we have to worry too much. It'll be a great tool to have in the toolbox, but we're not seeing these overwhelming kind of volumes of patients that are interacting with other counties. And I expect that same data will hold true in YOLO.
Yeah, I think, and because of the status of the fiscal side of this plan, I wasn't comfortable. Previously, I had grand plans to build out all these slots for CARE Act and really build in some cost into our MHSA plan. But with the fiscal sort of outlook that we have here, and because the numbers are so unknown for us right now, it didn't make sense to build a lot into this plan, but I do anticipate we may make some adjustments around that in the next annual update as we start to implement the program, see what referrals are looking like. I do know that our court, so the Self-Help Center, has been leading the implementation for the YOLO Superior Court, because remember, this is a civil court process, it's not a criminal court process. And I do know that they are anticipating some petitions being filed within, the first week or so of launch. They've had, I think, about 10 folks come and inquire about when they can file petitions. And so we'll be ready and prepared. We have to remember too that sometimes petitions are being filed on folks that the family members haven't been able to locate, right, or find. And so, but a big part of the process is outreach and engagement. And those are some of the activities that we'll be able to bill the state for and get reimbursed. And that will all help us to be able to quantify the cost of, running the CARE Act program locally, especially when, again, we didn't get the same kind of seed funding that the cohort 1 counties got. So just for example, Glenn County has 28,000 residents, and they got like $1.3 million to implement CARE Act because they were a cohort 1 county, right? So there was sort of a lot of money thrown at the first counties that were implementing. There was a small cohort of first counties. They got a lot of money to implement, and then there was no money left. So, but what we do get to benefit from being a cohort 2 county is that the cohort 1 counties have developed all the forms, the flows, the processes. So we are not starting from scratch. We are not recreating the wheel. And that's been beneficial for us for sure. And having more time to implement did work out better, I think, for YOLO, just from where we were in terms of staffing and resources. So I probably wouldn't have traded it, because we wouldn't be able to sustain the kind of teams that some counties hired for the CARE Act, because the petitions are just not seeing enough care.
Do you think that's because it's so new, or do you think that's because the process is very difficult to navigate through at
I
this
think
point?
it's probably both. I think it's new, so people don't really know, right? I think, there's a lot of work that can be done around educating the community and partners around what the CARE Act is and what it's not. I think that some people, believe that the CARE Act is a solution to homelessness, and it's not exactly that, It has very specific
It's not supposed to
criteria.
be.
It's not supposed to be, but I think it's been pitched as that sometimes. And then I do think that the criteria are quite narrow, so what's gonna happen with that? I'm not sure. Is the state gonna broaden the criteria? I don't know, but for right now, the criteria is quite narrow. And so, so folks may file a petition for someone, but they may not meet criteria. But in my opinion, that's also not a failure, right? Because then maybe they connect with the behavioral health system, and from our perspective, someone voluntarily engaging in services is the ultimate success, right?
Yeah.
Not having to coerce treatment through a care plan that's court ordered. But we also know there's a place for that as well, right? So for us, it's going to be really important to track all kinds of data, including people who engage voluntarily, right? Because we may go out and start an engagement, and they may say, yeah, I want services. So then they're not gonna go through this civil court process because they're voluntarily engaging in services. So, and we have something kind of similar. We
So
are,
you have a baseline for that now, right?
well, we're in AOT County, right? Assisted outpatient treatment, Laura's Law. And so we have 5 slots right now for a very similar process, which is a civil court process. It's very similar. The CARE Act is just a little different, has some specific criteria. And that's also not very widely utilized here. We may have 1 or 2 people. Sometimes we go long stretches with no one in an AOT slot. So we definitely have a bit of a roadmap, I think, for it, and we have some existing programming that we'll be leveraging, but it is our internal forensic team that's going to lead the process for us.
Want to make sure we get to Kimberly's question.
Yeah.
Yeah, so I had a couple clarifications about implementation of crisis now.
Sure.
So the facility that's being built, I asked you about this before, but just clarifying again, it's not gonna be 5150 designated.
It will not be 50/50.
Correct, so essentially, like, there's a lot of talk about crisis now replacing the current mental health crisis response system, right? But what I'm seeing is we're building 2 parallel systems where we're still routing people through the original system of police and ER. So.
Yeah, I mean, so I think what Yolo County could really benefit from would be CSUs, right? Where they could be 5150 designated. They're also an alternative site, but they do hold 5150 designation. The licensing and certification requirements for a CSU versus what our receiving center is are vastly different. So, in terms of my vision for what we need locally, I am hopeful, or, and it might be a little Pollyanna, my glasses might be rose tinted today, but with some of the Prop 1 bond funding, facility funding that's coming, I'm very interested in engaging with other partners in the community and talking about the development of a CSU that could be 5150 certified, because we know when we implement SB 43 and we have more people placed on, a hold for grave disability, or, when we may see an increase, right, in that, we're going to need access to those kinds of services. So for us, it's a bit of like, just continuing to build out the continuum, right? I hear what you're saying, and I don't necessarily disagree, because we still then are lacking that place that's not the ED, that's not jail, right? And we also don't have a place where people can go and stabilize when they're having a behavioral health crisis. So we still believe in the receiving center as a model, and we know we need more than that too, right? We know we need a CSU at some point. And the problem is funding, right? Like, there's these great opportunities with the bond funding right now, and it comes at the worst time for the county budget. It comes at the worst time for some of our own revenues, right? And so, and we have to have a match, even for these bond funds, you have to have a local match, at least a 10% match. And so, so I think that's some of the strategy, I think, that needs to come in the, as we look ahead around what do we need to really build out our system of care. And I agree with you, we need a 5150 designated facility, absolutely.
Yeah, and the other thing is, if providers don't know to refer to that facility, then they're gonna continue to use the old one. So if, for
Absolutely.
example, like, your co-responders are gonna be aware that the receiving center exists, and they're gonna take people to the receiving center, but are the police,
They're all very, very, the emergency rooms, and
I mean,
things they're our biggest customer. They're very aware and very ready, yeah.
I mean, I think the cities are gonna have our hope is that the cities are going to have a vested interest in that, especially because they're helping fund maybe, right, allegedly, they're gonna help fund the facility, right? But I think they have a vested interest in having an alternate place to take folks who are experiencing a crisis. And I think to the point you're making, getting out, just like with the CARE Act, getting out and educating our partners, providing training, providing resources, making sure people know the resources there is going to be very important, because it would be a failure to stand this up and not have it be utilized, because we won't be able to sustain it if it's not utilized. So it benefits us to have those chairs full, right? And to have folks coming in and using these services, and that's our intent. And we know it's gonna take a lot of community outreach and education.
Two of the core unintended consequences of very similar programs in other places were the big two are reduction in wall time for police officers. So waiting to 5150, someone at the hospital, the ER can take hours, right? Takes out for applying, all sorts of different issues, right? And then the ERs, obviously, that's just not the appropriate place for folks in those situations. The ERs would like to clear those vents too. So a big part of this is preventing it getting to that point, right? If that person actually could have gone to the receiving center maybe 6 hours before, or when they were experiencing symptoms last night, or maybe it's not quite a 5150, but the process of being detained actually escalates it to that point. So there's also some natural drivers that actually kind of drive police and emergency professionals to the receiving center instead too. And so kind of time and time again, these are the big benefits. And so this is also kind of our selling point to the cities and trying to get the police chiefs involved, and also the ERs, like I said. I mean, they're kind of waiting and seeing. The hospital systems have made a nice but small in the grand scheme of things contribution so far. But our big bet is that we're going to see those beds drop significantly and come back to hospitals for increased revenues. So it'll take some time to acclimate things a little bit, but all just by the nature of how it works, it sort of drives traffic to the receiving center.
Okay, and the other question I had was concerning, you're saying the someone to call part of the crisis now implementation is very has been well implemented, but when you're
Didn't say well, just said it's up.
But when you're talking about the someone to call, are you talking about well space for 988, or are you talking about the crisis and access line, or both?
All of the above, it's the same thing.
Because I know there's the no wrong door method, but then in terms of 988, there's still, because I know that they very recently kind of changed this, but 988 used to route based on area code.
It's a
They
statewide
still
issue.
do right now, but they
They
are
still- yes.
hiring now geolocation, so
Yeah.
that's coming.
Yes, that's an issue outside of our control, so it's a statewide issue, but it's getting there. So I'm sorry, but keep going.
Yeah, but essentially, when people talk about a call center, they think oh, the crisis and access line is fully the same thing as 988, when no, it's
No,
different.
they're different
They're
systems,
completely different things, and I
Right.
think there needs to be more public education about what each thing entails and
Sure.
who to call.
That's
for
good
what-
feedback,
for
yeah.
what
That's fair,
purpose.
Yeah, that's good feedback, and so, and you're right, so our contract for our high-tech call center, which is our access and crisis line, we are contracting with our regional 988 call center. And just because you call 988 doesn't mean you're gonna get routed to that call center, right? And so that's gonna change with the geolocation routing, which is great, and I'm so glad that they made that decision because it's desperately needed. I think it's a fatal flaw of 988 of how calls have been routed previously. But our call center is not necessarily, even though it's managed by the same provider, our call center is not the 988 call center. We don't fund the 988 call center because we have no say over 988 call centers. We have no control, we don't fund them. But for us, contracting with the regional 988 call center for our access and crisis line adds an opportunity for better coordination, right, than in places where that's not happening. So we are one of very, very few counties that even have the ability to do that because of how few 988 call centers there are in the state. There's only 12, there's 58 counties, right? So, but you're right, they're different. And I think we do need to educate folks because if someone just called 988, they're not necessarily gonna end up at our call centers right now.
Yeah.
Right now.
Yeah, and the last thing, so the stats from Crisis Now from June 2024, looking through a lot of it, so I want to clarify to make sure I'm understanding this. So this is all calls that got referred to mobile crisis specifically, right? It's not including the data that it was the police starting at 5150, it's just mobile crisis data.
Yeah, I'd have to look at what you're looking at, but yeah, I mean, if it's our co-responder data or our mobile crisis, then yeah, those are when a mobile crisis response is initiated. And so if a law enforcement officer places someone on a 5150 and they never engage with a co-responder or a mobile crisis clinician, that data would not be captured there.
Yeah, so
Yeah.
I think that's important to highlight, especially even in the calls that are at night, right? So the thing is, like, just because a call has not been designated specifically as a mobile crisis call does not mean it's not a mental health call that could have benefited from a
Absolutely.
clinician. Because like, I think a lot of the crisis now developments are really promising. But the thing is, like, what I'm concerned about is, like, let's not develop parallel systems of continuing to route people through the same systems of care where there's all these issues of like, okay, well, we have concerns about use of force, we have concerns about overuse of the ER, we have concerns about like, hey, de-escalation. But if we continue to route people through the same systems and we build a parallel system that kind of routes people to a psych urgent care rather than a psych ER, like, is that really doing what it was intended?
Yeah.
So I just kind of like pointing this out so that like people are aware.
Yeah, thank you.
Yeah.
That's good feedback. And I think, by accident, the co-responder model was sort of created and we quickly found out that it was successful and has some added benefits, like you mentioned, not only just changing culture, education, training, all of those different things by having that person embedded there. It embeds the system in kind of one streamlined system. At night, we have we have the AMR care cars, and it is kind of a separate, and so we're kind of grappling with like, how do you kind of sync all these things together? But running a 24/7 operation is very hard. All of the police departments now want their co-responders. They don't want a centralized model. So it's also very, very expensive. So we're kind of grappling with this. Like, how do we create a whole system today? And it's very different. But I love the way you phrase that, because it is, we sort of by accident, we're creating two separate systems and we need to figure out how to keep them together. And that probably wasn't the original design of Crisis Now, but it's starting to kind of end up in that vein. The only thing I'll add really quickly that I wanted to say as well is, so one thing that is actually going to dramatically increase the workload and bring no money and really harm the county financially, but not actually help people, is SB 43. So you mentioned CARE Act, SB 43 is coming very quickly. Thank goodness we were able to add those public guardian and service officers. Thank you so much for your advocacy. Even with the 3 that we added though, we're nervous about the volume, but that will add a tremendous amount of workload in the mental health, conservatorship, PG space. Frankly, we don't have the facilities, don't have the beds that we'll need for that either. So another kind of bill with great intentions, but not really practically applied at the ground level. But that is going to be a major, major workload issue for us, with no compensation from the state. It's 100% general fund. And like I said, Yolo County has one of the lower, if not lowest, general fund contributions to their Health and Human Services Department out of most of the counties around us. And that really challenges our ability to handle these things.
I just have 2 real basic questions.
Yeah.
I want to understand what you put forward. Is the unspent fund balance, is that a new piece here, trying to kind of deal with the volatility, or has it always been part of
We've
this?
always tracked unspent fund balance, that carries over. So
Okay.
we've and at the time, there's the slide we're working on will show you, just in CSS, Community Services and Supports, at one point we had $13 million of fund balance. So for many years, we were not spending, our fund balance was growing year over year. And there was a lot of feedback, we'll call it feedback, from the community, from this body, from leadership at the county to like, why are you sitting on money when people need services? We need to spend these dollars, right? And so, it's declined significantly, because now you see we're estimating $3.2 million in CSS, which means that we've spent down $10 million of fund balance.
I asked because you highlighted it, and I thought maybe that's one of the ways you're trying to deal with the volatility of
It is for us.
funding coming in, is to make sure that you keep sort of a minimum amount there.
And that's exactly what we're doing, is otherwise we would have put forward a plan that projected to spend every one of these dollars, because we could easily do that, because we cut $5 million from CSS in this plan alone. And so that's absolutely what we're doing, to try to give us the tiniest bit of cushion, because our prudent reserve is just over $2 million. And there are all kinds of hoops you have to jump through to access the prudent reserve. And so we don't intend to touch that.
I thought that was an important point.
Thank you.
So probably something
You're
that
right.
will come up as you move
That's
forward.
a great point.
Thank you.
Them understanding you're doing your part to try and deal with the
That's right.
volatility that's out of your control.
Yes.
And then the other question I have real quickly is that it looks like you did a very thoughtful and purposeful surgery and cutting what needed to be cut. And actually, I not lost on me that you looked internally as well to some of your positions, as opposed to trying to take programs that hit it all. I guess one of the questions I would have, and then may come up, is the cuts to programs.
Yeah.
Is that kind of spread evenly across the county, and everybody's going to feel the same pain, or will certain folks, maybe based on what's cut, be hit a little harder?
Yeah, that's a good question.
Where's the data? Where the RVAs?
they're at the end of the plan.
Okay.
I don't have them in here, but
Okay.
yeah.
Definitely.
Yeah, I mean, so I do think it's the cuts are balanced, you know, and I think we tried to offset services where possible. So very rarely is something just going away that there wasn't sort of a backup for. And some of the things that entirely went away maybe weren't serving the purpose that they were intended to, right? And I think there was a time where we had a lot of fund balance and a lot of revenue, and it was like, well, let's add this and this, right? It was like, it was a fun time, and I should say, right, when there's a lot of money to spend, this isn't such a fun time. And so this feels like right sizing and sort of focusing on some core functions, but I do think some folks will get it. I mean, you know, I'd be remiss not to say, we eliminated the Latinx Promotores program, which is a culturally specific program. I'm not, you know, have to acknowledge that. And because there's other funding attached to that, and many of the services continued on without the MHSA funding, I think it was the right decision to make, and especially in terms of what the future holds for us here. But that was a tough program to cut, and I do think there are some impacts there. The intent of that program was to increase folks coming, Latino community members coming into our specialty mental health system. We have not seen that sort of come to fruition for a variety of reasons, but that program hasn't necessarily directly impacted, right, what we're seeing in terms of our specialty mental health penetration rates. And you can see that in the RBAs, like there were 2 referrals to specialty mental health in a quarter, I think, you know, it was like very low, but there was a lot of services being provided otherwise, right? But it wasn't necessarily sort of getting to what we had hoped, right? Which was increasing sort of engagement in our specialty mental health system for our Latino community.
So knowing how you give presentations, I have no doubt that was the case.
Yeah.
That you really carved that up as you move this to a public forum. Those are questions
Thank you.
Yeah.
probably arise because they're going to just see that piece and whatnot.
Yeah, thank you.
How's this affecting me? Right? So-
Yeah, that's really good feedback. I think one thing I will encourage you all to do as you have time is to really look at those amendments, all of the RBAs. This board has been asking for data, rightfully so, for years. And I think we have RBAs for every
program.
which is, I mean, a huge abundance. So again, we're gonna have to
Some of
make
you
some
might
hard
not know what a big deal that is, but I have
Huge.
sweated a lot of sweat in these meetings about our RBAs, and so, you know, I think that, and Jonathan did say, I see that there's RBAs for every program. That was a very proud moment for us, I think, yeah.
We have to make a plaque of that.
Yeah.
But with that being said, though, and as the budget gets tighter, right, we're gonna have to make hard decisions, and we're gonna make them on data. So again, Joe, kind of talking about it, some programs have the best intentions, the most amazing staff, but if they're not producing the results they need to produce, they're gonna go to the top of the list of things to consider to move, because we're just not gonna have enough to fund everything. So I would really encourage you to take some time, grab a highlighter and a pen, scrub through that data, and really, we're gonna start making some database decisions. Unfortunately, on where we have to cut, not where we have to fund over the next couple of years, but hopefully at some point in time, the pendulum swings the other direction, and we start thinking of where are the most effective programs to dump our money into.
I agree with Joe. It was helpful to hear where programs may have been supplemented by other funding, and just really continuing to highlight that is important for people as they look through it.
Yeah, thank you.
And I think the one piece is, if there is something that is going by the wayside, what was the population being served by those services being eliminated?
Yeah,
And just, that's helpful information.
yeah, okay, yeah, thank you.
Could you go to the data navigation center, because I'm not sure I understood you correctly.
Yeah,
The way I understood you is that for the people who actually use it, they're not going to see any reduction in services, it's just on the back end, is that true?
for the most part, yeah. I mean, so we had a slight change maybe to the wellness center hours, but it was not being well utilized previously. We had very low number. I mean, there's a small number of folks who use it all the time, but in terms of broader utilization. And so we've been sort of testing out different hours, right, to try to figure out when we can have the most impact there. We're doing some strategic outreach as well, like going out to Pine Tree Gardens and trying to arrange for transportation for folks who are residing in Pine Tree Gardens to come to the Davis Wellness Center and use those services. And so I think for the community, they won't see a significant impact. We have a mental health clinician, crisis mental health clinician available. We'll have a behavioral health case manager. We have the wellness center staff with peers and with our own county, behavioral health staff as well. But it is a slightly reduced staffing, model. And so, but with the no-show rate that they were seeing with their assessments, we feel like it's right size for right now. And so we don't think that the community will experience it. The hours are the same, there's not a huge difference.
Okay, because that was highlighted as one of the things that should be expanded, and I assume we can't expand anything right now, but at least we're not.
But I think we can take some lessons learned for how that model's working, and as we're looking at our other clinics, and we have a West Back clinic, we have a Woodland clinic, which are both operated also by the county, so this helps align, right? It was wonderful, communicator did a great job at the Navigation Center for the last several years, so we have nothing negative to say about how they operated the facility. And it was, that was a sort of one-off where the county operates our other facilities, and so this sort of aligns those efforts, and then we can utilize staffing across, those three. And I think what worked in Davis can help us inform improvements at our other sites, and that's our intent.
And there's some mechanical issues with this as well. So when you approve the plan and the board subsequently hopefully approves the plan, these new positions are in there, right? And so we're kind of in this weird limbo phase where we can't actually hire, we need permission to hire, we've got to adjust the county's budget because these 3 positions are new. So there's all these other bits and pieces that mechanically have to happen sort of after you do your process, the board does theirs. And so we're kind of working through that. So right now we're kind of covering flexibly with our staff, which can be tough sometimes. I think the other thing that Carlene stressed earlier that I can't stress enough in this discussion too is that we have the control to bill Medi-Cal, right? So a contractor, we can ask them to or request it, but if we're not billing that primary revenue source, it really drives the costs up. And so by having that under county control in this one instance, we actually have some more ability to draw down revenue.
Any other questions?
Just to, you guys did a really good job.
Oh, thank you.
Yeah.
Yeah, you're well done. I just wanted to remind everyone that the draft plan is available for review through the 29th of this month, but also for our public. Where would they provide feedback? Like, what's the mechanism? Can you put that?
There's a link with where it's posted, where they can provide the feedback via the link. And then we're required to also post them hard, copies of it, and then there's forms where people can fill out to provide feedback, and then there's a Dropbox to collect that feedback. But primarily we get our feedback through the online submission.
And then Christina, can you make sure that's included in the minutes for this meeting, just in case somebody wanted to look that up?
Do we do like social media festivals?
Yeah, we do. I mean, we did a big release because we have a huge distribution list for the community engagement work group. I don't know if we did anything on our social media, so I can have Greg post, yeah. And then we also do post it in the paper, so it's going in the Davis Enterprise and the Daily Democrat. It runs for several days with information about the plan and about how to provide feedback. So that will also be posted for 3 days, I believe, in each paper. So
Thank you. Yes, so now we're going to open it up to public comment. Just a reminder that we may or may not reply, but we definitely encourage you, if you take a look at the draft, to utilize the opportunity to provide feedback. And then any public comment that you have right now, if you could do so within 5 minutes would be helpful.
Okay, I'm Kathleen Williams Hostal, and I donated Country Gardens West to Yolo County on September 16th of this year. I'm really amazed and proud of you guys for doing that because you have so many other obligations. And so I just really appreciate that you got that together to do. And because it took, I offered it in March 1st of 2023. So it's been a year, it's been a year and a half. So I was on pins and needles because I had to pay $16,000 a year in property taxes, which Yolo County doesn't have to pay, and $7,000 a year in commercial insurance. And those were great burdens because the property that I sold in Palo Alto, it made twice as much a month as I received from Arnie Heisen at North Valley Behavioral Health. And the expenses were 6 times greater. So it was very uncomfortable for me to own it for so long. I thought I would only have to own it 1 year, but an accountant told me I had to own it for 2 years before I could donate it. And that was March 1st of 2023. And so I was already struggling with an extra year that I hadn't expected. And then adding another year and a half was very stressful. So thank you for looking for $100,000 to pay me so I can pay off my debts that I accumulated. I had to get a couple of 0% APR loans. And of course, they came due once a year and I had to struggle to do it again. So I'm going to really appreciate paying back all the expenses I wasn't expecting. And it includes, I had a fire in my quadruplex in Davis, damaged the kitchen, and it cost, I received $37,000 to fix it. And I had to use that money to pay the property taxes and commercial insurance. So that poor tenant has lived without a kitchen for quite a few years, paid less rent, of course. But I'm gonna fix her kitchen. As soon as that $100,000 comes in, I'm fixing her kitchen. So anyway, thank you for looking for that $100,000 to give me, and it's supposed to happen in the middle of December. So thank you for completing that part. I've worked really hard to have this happen, and my parents worked hard for it to happen. You've made it happen in spite of all the extra jobs and things you had to do. You found time for me. That's so sweet of you. The other most amazing thing is your county came up with the 99-year title arrangement so that it could be used for its current use for 99 years. And I don't know how you did that. That's remarkable. Turning Point community programs, they only guarantee 50 years of use. Well, you outdid yourselves, and it's a miracle. So I couldn't have done it without you. You did the miracle. Thank you.
We couldn't have done it without you.
Thank you.
Yeah, I'm Jen Boucher-Danzer, Executive Director with NAMI Yolo County. I also want to thank Kathy for her incredible generosity and support of the mental health community in Yolo County. And also really just thank you to Carlene and your entire team. You have worked so hard making what are obviously some really painful and difficult decisions. And we appreciate you at NAMI, and also greatly appreciate your willingness to work with us at NAMI to, help us be able to preserve the programs that we offer at no cost to the mental health community as well. It took us a little while. Our board had a lot of questions, and so, Carlene and her team were really both generous with their time, as well as, helping to really explain everything to us and guide us through that process. So thank you to you and your entire team for all of your work.
Any other public comment? Online? Well, I agree. Thank you. We put a lot of effort into these presentations, and it really showed. And they're all the things we've been asking for years. So we really appreciate that.
Thank you. Thanks. And when we come back in December, we'll present a final plan of any adjustments made based on feedback. And we'll also go over all of the public comment we received and any response to that public comment with you all at the December 6th meeting before you decide, your recommendation or not to the board. So that'll be sort of the end of that process when you hold the public hearing. So we'll be back next month. And again, really thank you for making the time tonight when you should have had the month off. So we're very, very grateful. Thank you.
Is there a motion to end?
You can just adjourn.
All right, we adjourn then.
Thank you.
Yeah.
Yeah.